Assalamu alaikum guys, welcome back. IOP or intraocular pressure is a daily one of the basic things in the life of an ophthalmologist, usually in glaucoma clinics, because usually the glaucoma patients are associated with rise in intraocular pressure. So these patients, when they come to OPD and follow-up visits, or if a new patient come, we usually the first thing, or we need to keep it in mind to check the IOP of these patients. Now IOP is intraocular pressure is the force or the pressure exerted by the aqueous humor, that is the liquid inside the eye, in the front of the eye, in the anterior segment. So that aqueous humor, the pressure it exerts on the eye, is known as IOP. Now the normal range is between 10 and 20 millimeter per mercury. Now before going into the measurement of IOP, intraocular pressure, you need to keep it in mind that there are two types of IOP measurement: direct and indirect. Now the direct, as the word suggests, we place a tip or an instrument that is placed inside the eye, and as a result we get a direct measurement of the IOP. But these methods are not usually used these days, because if you penetrate the eyeball, it can cause infections, or it can cause pain to the patient. So there are other newer methods that are used recently, so that method is rarely used. But you need to keep it in mind that there is a direct method to measure IOP. An example in the direct is manometry. You can see it in the image here. Now in indirect, there are various methods. Let's discuss them one by one. So the indirect is further divided into three parts: applanation, indentation, and palpation. First, let's discuss palpation method, because it is one of the easiest method of all these three, and it is usually unreliable, but in cases of emergency or any if you need to make quick decisions, you can do palpation method in patients. Now, as the word suggests, palpation, we palpate the pressure, we palpate the eyeball, and with the help of palpation we get an estimate of if it is hard, we can say the IOP is raised. If the eye is soft, we can say that the IOP is low. So you tell the patient to close his eyes, tell him to look downwards. With your two hands, the two index fingers, you place it on the eyeball. With one index finger you exert pressure, with the other index finger you feel the pressure. So this usually comes with experience, and it is not an unreliable method, but it can give you an idea about the pressure inside the eyeball. Now let's come to the applanation method. Before going into applanation method, the word applanation means the force required to flatten a part of cornea, temporarily flatten a part of cornea. So that pressure that the instrument exerts to flatten the part of cornea is our IOP reading. The applanation tonometry is further divided into contact and non-contact tonometry. In contact tonometry, the Goldmann applanation tonometry and Perkins tonometry that comes. In non-contact, as the name suggests, there is no contact between the device or the patient's cornea. And in this one, there is air puff tonometer. So in this video, we'll be talking about only Goldmann applanation tonometry, and the other one we can make another video on that. Now there's a Goldmann applanation tonometry, which is the gold standard used worldwide. It is the ideal of all the IOP measurement methods. And there's a Perkins tonometer method. Perkins also has the same principle as Goldmann, but the thing is, Perkins tonometer is mobile, you can take it with you anywhere, and Goldmann applanation tonometer it is usually fitted in the slit lamp, so you cannot take it anywhere you like. And an indentation method, the last one, is Schiot's tonometer. So let's discuss Goldmann applanation tonometer. You usually see these images, as you can see here, that there are two Myers. You need to approximate them. So what are these two Myers? In Goldmann applanation tonometer, the probe or the biprism, that is the part that you usually touch with the cornea, that biprism has these Myers in them. So first of all, you have to instill local anesthetic drops to the patient so he doesn't feel pain. Then you stain the eye with fluorescein strip. So once the eye is stained, then you use the cobalt blue filter, and then these biprism, which are having these Myers, you bring them towards the eyeball, to the cornea, the center of the cornea, and you applanate the cornea. So once you touch the cornea, you will see these Myers in your slit lamp, and these will be stained because you have already stained the eyeball. So the inner circle of these two Myers, these two semicircles, the inner part of these two semicircles, they should be just touching each other. That will be the ideal reading on the dial. If the Myers are away from each other, that means the pressure is high. You need to increase the dial reading. If the inner part of the semicircles are close towards each other, they are gone inwards, then that means the pressure, you have exerted more pressure, you need to lower back the dial reading. And if they're just touching each other, as you can see, then that means this is the ideal reading. Now remember, this comes with experience, that how much you have to advance towards the cornea, how much pressure you have to exert. Usually you get thick Myers, very thick Myers. That is because you have stained the eyeball too much. So you tell the patient to close his eyes, you clean off the excess dye, and you try again, clean off the biprism, you try again, so that you get thin Myers. The thin Myers are the ideal ones. And remember, this comes with experience. Like I said, you have to, how much you have to advance, how much you have to pressure you have to exert on the cornea. And but the ideal method is that you pull the joystick back towards yourself, you bring the slit lamp, the whole set towards the patient, so when the biprism, the probe is close to the cornea, then with the help of joystick you make fine movements slowly and gradually. Now you do not have to move the whole set, you just have to move the joystick, and the joystick results in the fine movements of the probe. So slowly and gradually, the point you get 2 Myers on the eyepiece, that is the point you stop, and then you adjust the dial reading so that the inner circles of the 2 Myers meet. And in the dial reading, the readings are 1, 2, 3, 4. Now you have to multiply it by 10. So if it is 1, it becomes as 10 mm per mercury, or if it is at 2, 20 mm. Between 10 and 20 it is normal. So if it is more or less, then that can result in increased pressure or decreased pressure. If you have any questions regarding how IOP measurement is taken, or how it is used, how the measurements are taken, please do comment, and I will try to make another video on it. Until my next video guys, take care.